Jason Farley, I really want to talk to you about the lingering effects of this virus. Is it tangible? Is that fatigue genuine?
Well, good morning, Tom. So absolutely, we're seeing continued emerging data. There was a recent publication in the Journal of the American Medical Association, highly respected journal, showing that they followed patients after their initial onset of symptoms for up to 2 months after they initially became sick. And they found that patients' fatigue was the most common symptom, but they also had lingering symptoms from their respiratory system, so cough and some difficulty breathing at times. Some patients, although a smaller proportion, less than 20%, still have problems with taste and smell. So I think we definitely are seeing some subgroups of people who have longer symptoms.
Jason, just to add to that, what have we learned about reinfection?
Yeah, we continue to see cases of small numbers of cases, let's be clear, but small numbers of cases of patients who we've identified have recovered from the infection and have a documented negative test, in some of the cases repeatedly negative, and then have subsequently developed coronavirus again. It was always within the realm of possibility. We talked about it on this show and in others. That would possibly occur. And now we're just seeing small numbers of cases where that information is growing.
Jason, what's the latest on the infectiousness of children? Initially, there was a theory that perhaps they were not infectious. Those of us who have children said that can't possibly be, since they are vectors of disease. Now the idea is that they can spread the virus. How are we looking in terms of how they compare with the degree of spreading it versus adults?
Yeah, so, well, there are a couple of points there. So in terms of how good a child is at spreading compared to an adult, really they have as equal a probability of transmission depending on their viral load and how much virus they have, and then how much contact they have. So that's the first thing. We were wrong initially about them being less spreaders. With certain infectious diseases, with small kids in particular, like the really little ones, their cough is a little weaker. It's not as forceful. So you would think of, if you think of Pigpen and the cloud of dust that goes around them, that cloud of dust around the children is a little smaller than around adults. So there's some data to support that they may be able to spread aerosols a little less far. But overall, they carry a similar amount of virus and therefore are as equally infectious as their adult counterparts or family.
Jason, just to round out the interview, let's try and finish on a positive note. The improvement in therapeutics. We're all looking at the case count. We're looking at hospitalizations again. Jason, walk me through therapeutics. How much has improved over the last 6 months or so?
Yeah, so right now we've got, definitely a glimmer of hope. So most of the world is now using remdesivir with or without dexamethasone. So with those two agents, and it all depends on whether or not you need ventilation or oxygenation, and that's how the recommendations around the world are moving forward. People who need oxygen get dexamethasone or remdesivir, and then people who need mechanical ventilation likely get both. There was a recent study that just came out from the WHO that's still under peer review that calls to question, again, the mortality benefit, the death benefit of remdesivir. But we had already had good data that showed that remdesivir did not reduce death. It reduced symptom burden. So again, another study that seems to be similar to what we already know. So what we're seeing is cases of patients having greater access to these treatments, which is also going to help us reduce ultimately the mortality level as we can scale up these interventions.